Welcome back. This is a continuation of the robotics program. In this section, we're going to talk about accountability. And that's probably one of those things that we take for granted a lot of times. We always think that somebody's, of course, accountable to somebody else. You may look at your team and say, well, every single person here is accountable to somebody. So why do we have to talk about accountability? And how is it that a program has to have accountability that seems to be separate from the individual accountabilities of those that are members of your program? I'm going to go through that and explain in, I hope, in enough detail for you to understand why this is extremely important. First off, though, what we're going to have to do is talk about what is accountability. And because everybody has a different definition, I'm going to define it for us in this program. Accountability refers to what type of governance structure your program will use in order to function most effectively in your organization. And so before we go into the different models of accountability, I want to talk about governance and why it's important. The first thing is if you're working in a hospital or healthcare system, you have some type of governance structure in place already. It's already there. If you're part of the medical staff, you have a medical staff governance structure. You probably have a MEC, or also known as Medical Executive Committee. You have departments, you have divisions. They're all reporting up. You have division heads, you have department chairs, and you have probably a chief of staff and vice chief of staff that are running your Med Exec Committee. That's a medical staff type of governance. In the administration side, though, you're probably going to have a CEO and a chief medical officer, chief nursing officer, a chief administrative officer, or sometimes some people have a chief operations officer. But the idea is that there's a governance structure because those people have people who are reporting up to them. So a governance structure exists in your organization already. And the one thing you really don't want to do is you don't want to be the lone wolf. You don't want to be the group that just says, we're just going to meet. We're going to go off over here and meet in this room, and we're going to be the robotics program because, we think we can do it better. That's a big mistake. I've been involved in groups like that who just kind of what we call, sort of self-governed, and they have very, very limited abilities to make change in large healthcare systems as well as hospitals. They just do. There's some things that they can do, and they can do it very quickly. But for this type of program, I wouldn't recommend that. What I would say is you have to figure out how you're going to fit your governance structure, how your program is going to fit within your hospital or healthcare system's governance structure. And we're going to go through the different types of models that are out there, and we're going to talk about the different types of things you can do in order to get the best out of each model. Because not any one of them is perfect. They all have their functions, they all have their uses, and you have to be able to find out which one's going to work most effectively in your organization. So while I may have some preferences, it's simply based on my experience or the types of places where I've worked in the past. You may be working somewhere else that's very different, and therefore that model would work more effectively. So we're going to talk about the three different models. And again, these are pretty basic things that you probably have seen and heard of before. But you need to understand that they will impact how your program functions downstream. So it's important to kind of understand exactly where you fit within the governance structure. Three basic: medical staff, administrative model, and then I'm going to call it an alternative or a hybrid model, which is pretty much tries to take from the best of both of the two aforementioned models. So let's first talk about medical staff model. We're most familiar. Like I said, it usually has some type of Med Exec Committee, has a chief of staff who's elected individual, sort of vice chief. Sometimes they have a secretary and a treasurer who are also part of the Med Exec. And then they have standing members who are all elected into that model. These are members of the community, members of the medical staff. They usually have an active type of profile for their medical staff, and are usually people who've been around and are very well informed about what's happening within the hospital. There's some great things about medical staff model. I'll tell you this. First off, it has an established infrastructure. So all of those things we talked about in infrastructure are taken care of for the most part with a medical staff model. I told you about that whole thing of how do you organize physicians, and is it really going to be like herding cats? Well, in medical staff model, it's usually not like herding cats. Usually you have somebody from medical staff services who's going to be doing all of the logistics for your medical staff model. So typically what will happen is you come up with the idea that we need a robotics program, so therefore we need a robotics committee. Where does it live? Well, it might be under the Department of Surgery, it might be under the Department of Gynecology, it might be, somewhere else. But the idea is it's probably going to live somewhere, or it may have some sort of direct reporting responsibility to the MEC, meaning it's its own separate department. I've seen people do that before where they called it the Department of Minimally Invasive Surgery, and they had a multidisciplinary representation that then reported up to the MEC. Nothing wrong with it. That's pretty good. That could be a really, really good model. I've seen it work successfully. If it works at your organization, then that's probably the one you're going to want to do. And like I said, the nice thing is you've got built-in infrastructure. You've got somebody from medical staff services who helps you develop an agenda, helps cover the meeting minutes. They're always typed up and they're put somewhere where everybody can get access to them. And they do all of those really nice things. They find the room, they make it the same date, the same time. They're really good. They figured that out. They realize that's what gets physicians engaged. That's why they do it. So they try to avoid all of those disengaging things that you see a lot of times when you don't have somebody involved who works with medical staff. And so that's the nice thing about it. It's an established governance. You know who you report to. If you're reporting to the Department of Surgery, it's the department chair who typically picks, or sometimes it's an elected position, but typically will pick who's going to be the chair or the lead of the medical staff robotics committee. The nice thing is that if you have problems, you go to that person. That person helps you resolve those problems. It's a really nice way of having an organized approach to your robotics program. You have strong ties to your medical staff leadership, having those people on board with you, because if they decided that they needed a robotics committee and you're going to be the lead of that committee, they're behind you. They don't go to the trouble of establishing another committee. Like I said, a lot of physicians already don't like to go to more committees than they have to, and they certainly don't want to sit in one that is not supported by its leadership. So leadership and medical staff, if they get to the point where they say, yeah, we're ready for a robotics committee, and you're going to be the co-lead, or the lead, I should say, then it's important for you to recognize that you have they are behind you. They're supporting you. They've got your back on this one. And so that's the nice thing about it. Medical staff model is a pretty cool model, which is part of the reason why it's had such a lasting appeal over the years. The cons, and that is a potential for interdepartmental squabbles. I saw this happen where they decided that the robotics committee was going to sit under the OBGYN department. And guess what happens when a few general surgeons and urologists show up? They go, well, according to our bylaws, you don't have voting rights. And all of a sudden, it's like, what do you mean? It's like, well, you're not part of our department, so you don't have voting rights. Yes, you have your medical staff, but according to our bylaws. And so you got to read the bylaws. You got to make sure that your rules and regulations allow for that to happen, because if it doesn't, and you expand your program, you can start getting into interdepartmental squabbles. And how that one happened was the people who were using the robot initially were just gynecologists. There were no general surgeons. There were no urologists, no CV surgeons, no ENT surgeons. None of them were using it, just the gynecologists, and that's why they parked it there. And for a while, it was really, really a very successful model because they didn't have anybody else in there. But as soon as the general surgeons got involved and the urologists got involved, now they started having interdepartmental squabbles, and the general surgeons and the urologists were always getting outvoted because they had the entire department of gynecology standing there who could always outvote them. And so not a good way to run your program. And that's how, if you use this, you have to be very aware of that before you get yourself into that situation. The other thing is nursing administration do not have voting rights. Now, you might say, well, that's good. We don't want them to have voting rights. No, actually, it can get in the way of a lot of things. When people don't feel like they're a part of the team, part of the membership, they generally tend not to have your back. You're not always trying to find ways to make sure that you get what you need. And so I'm not saying your nursing administration are going to work against your robotics program. It's just that they have other priorities. And when they feel like they're getting left out, and particularly when they don't have any voting rights and they can't participate as an equal member of that team, there's a tendency for them to back off and kind of go, okay, well, you run it yourself, and we'll help you when we can. And you can find yourself in that situation very, very quickly. So just kind of keep that in mind as you're establishing your program. The other thing is medical staff models are really good for serving the needs of medical staff, but they may not necessarily be very effective. And most times that I've observed, they're not very effective at all changing operational practices. If they want something changed in terms of how the organization is approaching robotics from an operational standpoint, they're really going to need buy-in from nursing administration. And like I said before, if nursing administration don't feel like they have a equal place at the table, they may not necessarily be completely supportive of what you want to change. Remember, they've got a lot of other things going on, and this may not be one of their priorities. But if they're part of the team and they feel like they have an equal say and they approve of the changes that are coming along, they're more likely to go out there and support you. So medical staff model will only get you so far, but when you're trying to do certain types of things, it's very difficult to get that done. The other thing to remember is a medical staff model, if you're looking at a system model rather than a facility-based model, a medical staff model is probably going to fall far short in a system model. A lot of it just has to do with how bylaws are set up. Medical staff of a particular facility are arranged around that facility. They're not arranged around a particular system. And so trying to get things done across the system at a robotics system level committee is going to be very difficult. It's trying to align all of those medical staff in support of that model, and trying to decide how do we elect a lead, and how do we establish membership, and who has voting rights on that. It's almost impossible to pull that off at the system level. So system level almost always ends up resorting to an administrative model. The facilities, though, not uncommonly will continue with their medical staff model. We had a mix, and I'll talk about it a little bit more in our hybrid, which is we had a mix. Our system was an administrative model, and then we had some of the facilities that had an administrative model, some that had a medical staff model, and then some that had a hybrid model. When we get to hybrid model, you'll understand why some of them chose that. But we really found that if we were flexible with our medical staff across our system, that was possible. The whole idea that you have to have one single model is probably not realistic in many systems. We were even though our organization was an operating model, meaning we had one board of directors, one senior management team for the entire system. The facilities, in many ways, particularly on the medical staff side, tended to have a lot more say in what was happening at their facility level with regards to specific service lines like a robotics program. And so we found that we had to do that. It was basically a way to keep peace in the family. It was a way that worked for us. You may find, though, that you want to go to a single type of model for the entire organization. Maybe you're just going to have one administrative model, and that's the way it's going to be. And if you're going to do that, it's probably going to be an administrative model or some type of hybrid model. Those are a little bit more difficult to pull off, but they have a lot more flexibility downstream, and they are probably more functional in terms of getting things done on an operational standpoint. So for an administrative model, the pros, and I've kind of alluded to many of these, multidisciplinary approach promotes inclusivity. I knew I was going to screw that one up. Inclusivity among stakeholders. So the having people at that table and feeling like they are inclusive in the process as an equal member is going to get you better buy-in downstream. And so if nursing feels like they have a say in what's happening in the robotics program, you're going to get a lot of support among nursing. If your administration feels like they have a say in the robotics program, and you're going to get a lot of support from your administration. If it's just this is my program and only doctors run it, and I'm the lead and I'm telling everybody what to do, it's kind of my way or the highway, you usually don't get a lot of support. And that's what happens. You could see, I've watched so many programs, not just robotics programs, so many programs just bite the dust purely because they have somebody who gets in there and says, it's my way or the highway, and then nobody supports them, and guess what? It's the highway for everybody, and it doesn't work out. So just keep that in mind. The other pro is strong ties to the C-suite. Administrative model, obviously, is purely by governance, reports up to the C-suite. And that is important because your C-suite is the one who made the decision to invest in a robot and the robotics program. And so they're going to have a vested interest in it. They want to see it be successful. And so that strong ties to the C-suite is really particularly important. Greater access to resources and data, definitely on the resources side. When you go to them and say, if we're going to have a robotics program, I need an administrative assistant. And they'll say, okay, we'll find one for you. But like I said, I would find one that had maybe some experience in medical staff services, because I just think that they're almost magicians in terms of how they can pull things together for physician meetings, particularly these types of meetings when they're first starting. So I would lean more and more towards someone who has that type of experience if you are going to lean on the administration to get you an administrative assistant. The other piece is the data. it's really difficult to get data on medical staff. There's quality reports and there's some other things that pieces of data that medical staff will get access to. But as a general rule, having seen what data is out there and having seen what data gets filtered down to medical staffs across our system and in other hospital systems, I can tell you there's a lot more data out there than you could ever imagine. And I'm not saying necessarily that more data is better, but sometimes it's specific data that's really going to help you make the effective changes in your program. So having that data, having access to the people who can abstract that data is going to be a lot easier with an administrative model. Having access to the people who can do statistical analyses of that data is going to be really important, and it's more likely under an administrative model. And having somebody who can interpret the data, and hopefully you as a leader are somebody who can look at this data and help interpret what it's trying to tell you, because that's going to be a real key piece. The first two, the abstraction and the analysis, if you don't know how to do it, if you're not good at that or don't have any experience doing that, it's going to be a stretch to think that you're going to get it through your medical staff model. They usually do. They'll assign somebody, but my experience is it generally tends not to be a dedicated resource. And if it is, it's usually somebody out of quality who already has canned data for you, who's already bringing it to you. Maybe they're showing you data on core measures and things like that, which is okay. I mean, you need to see that data, but I think for the type of program, you're going to want to play with the data initially and find out what works for you and what you need to be looking at. And then, of course, greater support for operational changes. If you're going to make any operational changes, administrative model is the way to do it. Medical staffs across the decades have been frustrated at their inability to get operational changes, and they think it's always administration is trying to get in their way or be obstructions. They really aren't. At least that's not been my experience. What it is they just have other priorities, and so they always think of medical staff as taking care of their own. They take care of themselves, and we take advice on operational changes. We really don't necessarily work with them to generate operational changes. I think that's changing. I think as more and more physicians get some business training behind them and take on more operational roles, I think administration is becoming more trusting of them. And as they do, you'll start to see more input on the operational changes. But I think in terms of a model, this is probably one that'll be a better one for accomplishing that. The other alternative is if you have a medical staff model, this is to bring your chief medical officer or chief nursing officer in on your program. Those are two people who have a sense of how to get operational changes to occur in your organization. And I think it's important to consider them as a member of your committee. I don't think they're an absolute necessary, but when you're running into those types of problems, that's when you want to bring them in. The cons of an administrative model may lack adequate skills around organizing physician meetings. It's been my experience over and over and over again, and I've been always frustrated when someone says, "Well, so and so will be, your assistant. They'll take care of all the organizing," and I just cringe when I find out that it's somebody who's never organized physician meetings before, because I can pretty much guarantee that it's just not going to go well for the first few meetings, because you have to get them up and running on them. A lot of people who've never worked in medical staff services are very a little gun shy about calling up a physician and saying, "Hey, do you know you need to be at this meeting?" A lot of the times they just don't see that as their job. They don't think that they can do that, or they don't feel comfortable contacting a physician and telling them they have to be at a meeting. Medical staff services, they have no qualms about that. They're very good about that. They're downright assertive about it, because they know that the success of medical staff is dependent on engagement of medical staff members, showing not only engagement but also showing up at the meetings and participating. And so it's a key piece of success. But if you don't have that in your administrative model, find somebody who knows how to do it. That's going to be that can really kill you right off the start. The other one, inexperience with dyad leadership model can create conflict among the dyad leadership. So if you create an administrative model and you have a dyad leadership, so two leaders, it's usually a physician and a nursing co-lead. I have seen where you had an administrative individual who was the co-lead. You can do that as well. I'm not saying you can't, but more commonly it's going to be someone from the nursing who's going to be your co-lead. And so this is an equal co-lead position. A dyad is an equal partnership. Physicians a lot of times have a little hesitancy, and even nursing has a lot of hesitancy, and will find themselves deferring a lot of times to physicians. You have to find somebody who's assertive enough, who feels comfortable enough, and is confident enough to be able to pull that off if you're going to do it. So what can happen is you'll start to see it's really not a leadership, is it's so much, or you'll see like a leader and sort of like a sub-leader, type of relationship. I think that creates a fair amount of dysfunction, unless it just works for you, then in which case just call it that. Say you have a physician lead and you've got another person who's going to be your chief, who's going to be your nursing lead or something like that. But I support a dyad leadership model. I've had a lot of success with it. I've been also fortunate to work with a lot of those in nursing administration, those dyad relationships, and I think sometimes it's just a lot of it just depends on who you're in that dyad with. And like I said, I've had good luck, and so because of that, I tend to be more in favor of that type of model when you're going to use an administrative model. But it doesn't have to be that way. Some people will just say, we're just not comfortable with dyad leadership, and we're just going to have a physician. He's going to be our medical director of our robotics program, and that's just the way we're going to do it. That works too, by the way. It's all about figuring out what works in your organization. And part of that is understanding your culture. Understanding, is your culture ready for an administrative model? Has it ever used that before? If it hasn't, then it's going to be very new and it's going to be a little rocky waters at first. On the other hand, if you've had experience with it and you've had good luck with it, a good chance you're going to be able to pull it off. So I would consider it strongly if you're leaning in that way. So an alternative model, which is really sort of a hybrid model, that has capitalized on the best of both worlds, both models, so to speak. And what it does is it uses the medical staff model's infrastructure and the administrative model's multidisciplinary approach to optimize its effectiveness. So you're using an infrastructure based on medical staff, that is the experts in that area, and you also go to the experts on the administrative side of things, who are particularly in terms of the operational piece and the nursing side of it, and you bring them in together. It requires a lot of creativity in cooperation between the medical staff and administration. And because it's not a formal part of the medical staff, typically, there tends to be a little bit of uneasiness if you've never done it before. But it can work, and you really should consider doing it. I've also seen another type of alternative or hybrid model, which is you have a department of minimally invasive surgery or you have a department of robotic surgery. And that department reports up as a separate department up to the MEC. That department has members who are surgeons who work on the robot, regardless of whether they're general surgeons, gynecologists, urologists, ENT or cardiovascular. It really doesn't matter. You can pull that off, and if your medical staff's willing to try that. But again, a little bit of creativity, a lot of cooperation between the departments. They may not be used to that, When I was training, it was the departments sat on their own, and they very rarely talked unless they really had to. That's all changing now. Healthcare is changing so much, and this whole idea of cooperation, collaboration is becoming more and more important. And those that have the skill sets in that are going to be the ones that really kind of decide where healthcare ends up going. So my recommendation is this: use the model that's the best fit at your organization. You know your organization better than I do. I could come in there and take a look at things and make a suggestion. My guess is you already have a pretty good idea which one's going to fit at your hospital or in your healthcare system. Keep in mind, though, the most successful programs, at least that we have seen, are those that report to both medical leadership and the C-suite. You got to have, if you have those two groups on your side, it's really sort of unstoppable in terms of what you can accomplish as a robotics program. And we find that when they have those two and they're sitting at the table and they're having a conversation around utilization, cost, and quality outcomes, you see some real changes. And I think, to me, that's really where you want to get your program to, being able to have those discussions and being able to move it in that direction, because that's what this is all about. But the important thing to remember about this whole idea of accountability, though, is there's a governance structure. It's in place. You're going to be reporting to somebody, and you may not like that. You may think, "Oh no, I can do it on our own." You can try it. You can. I've tried it before, and I just didn't have that level of success that I had when I understood the infrastructure that's in place for the governance. And once I understood that and understood what is the best way to incorporate this in, then I was able to get a lot more traction with the types of programs that I was setting up. So keep that in mind. It's an important piece because others won't let you forget it. If you try to do it on your own, I hate to say it, but you'll find yourself in the penalty box quite often. And that's purely because you just didn't know. You didn't realize that people want you inclusive of the governance structure that currently exists in your organization. And that's just my advice. Questions, as usual, get a hold of me at terryloftusmd@gmail.com or visit www.loftushealth.com. And I thank you very much. And please move on to the next section of this course. Have a great day. Bye-bye.